From the classroom to the emergency room, OR and beyond, you're joining Trauma ICU Rounds with your host, Dr. Dennis Kim.
Welcome back to Trauma ICU Rounds. I am very excited to introduce our guest professor this week, one Dr. Megan Brenner. Dr. Brenner is a clinical professor of surgery at the University of California, Riverside School of Medicine. She completed medical school at VCU, followed by general surgery residency at UCLA. Go Bruins. Following this, she completed her trauma surgical critical care fellowship at the R.A. Cowley Shock Trauma Center and is one of a handful of American trauma surgeons who have completed fellowship training in both trauma surgery as well as vascular surgery. She stayed on as an assistant professor of surgery at Shock Trauma, where her research interests in vascular trauma and the use of endovascular technology, specifically REBOA, or resuscitative endovascular balloon occlusion of the aorta, really began to flourish. I think there's no doubt in anybody's mind that Dr. Brenner truly has been one of the leaders in the development, refinement, and application of REBOA as a therapeutic adjunct in the management of injured patients with non-compressible torso hemorrhage who are unresponsive to initial life-saving resuscitative efforts. Megan is a graduate of the American College of Surgeons Committee on Trauma Future Trauma Leaders Program, and she currently serves as the Director of Surgical Research at Riverside University Health System Medical Center. Dr. Brenner has published numerous publications and has many presentations to her name. Further, she is an avid and dedicated educator and was instrumental in the development of the American College of Surgeons BEST program. That's the Basic Endovascular Skills for Trauma program. And if you have yet to take that course, I would highly recommend it. I've taken it, I think, a couple of times and have found the tools and the skill set learned really invaluable, especially if you or your center and partners are thinking about implementing a REBOA program. So, Dr. Brenner, I want to thank you so much for meeting with me. I know we've been trying to get this interview done for a little bit of a while. Many people probably don't know this, but at some point in the last couple of years, you and I took a call at UCLA. And the last time I think I saw you was probably passing each other in the elevator as maybe you were going off a call and I was coming on call. I'm really excited to talk with you about REBOA. I think when I look at the modern care of injured patients, we have the hemostatic resuscitation, damage control, surgery. But when I think about new techniques or therapeutic adjuncts to help in the management of trauma patients with non-compressible torso hemorrhage, it really seems that REBOA is the one adjunct that has really garnered a lot of attention as well as controversy. And stemming from your original case series back in 2014, I believe, with an N of 6 till now. And so over the course of just several years, things have really exploded when it comes to development, refinement, as well as research around REBOA. I just did a PubMed search today and found over 400 publications in the last 6 or 7 years alone. So it would be great if you could share with us, Megan, what have you seen change over the last several years when it's come to REBOA?
So I think, as you mentioned, a lot has changed, but there's 400 some odd publications out there, which is great. I think the rapid adoption is based on a couple of things. One is it's something that we need. We need to get better at preventing patients from bleeding to death. And there's been, plenty of data out there that demonstrates that we're not getting better with stuff like ED thoracotomy. Our, survival rates from non-compressible torso hemorrhage are not getting better. So I think, one of the reasons is that there's a demand, right? There's a need for something, whether it's, foam, whether it's a balloon, whether it's anything that we can do to kind of help that, I think is going to, carry some change moving forward. So I think technology has a lot to do with it too. That obviously, being an endovascular kind of procedure, although a fairly basic one, if it's, done carefully and correctly, technology certainly helps us drive adoption and drive outcomes. And I think that's we're going to see more of that, in the next few years, just because REBOA is not, it's not going anywhere. We definitely have a ton of work to do to figure out who to do it in, what's the best way, who to do it, and when, what do we combine it with in terms of resuscitation and treatment, and how soon do we have to let the balloon down, and what do we do? There's so many things we still don't know after 7 years. So in some aspects, we've kind of rocket ship style adoption, but at the same time, we still don't have a ton of really specific data. But I feel like that's not uncommon for new technology and new procedures. So I feel like, we just have to keep pushing forward and looking at the numbers and collecting more data as best as we can.
Yeah. And on the topic of technology, I mean, there have been some significant changes in terms of the technology and the catheter that we were using, let's say even 5 years ago, to modern day REBOA. I remember when we first started doing this, we were using a 9 French Coda sheath, and you had to railroad that thing across a wire from halfway across the trauma bay. And now we've got this 7 French sheath, which we kind of put in if we need to, and really kind of focus on getting that early femoral arterial access in patients whom we deem, or your center deems based on your institutional protocol, may potentially benefit from having early arterial access. And in those patients who fail to respond or transiently respond to initial resuscitative efforts, well, then you've already got access to the femoral artery, and that can be simply swapped out over a wire for the much smaller sheath that we're using these days. And again, I have to say, as early adopters here at our shop, we have some pretty good experience and results using REBOA, and it really is incredible. When you have a patient who's non-responsive and they're progressively becoming obtunded and they're hemodynamically unstable, once you get that balloon up and you inflate it, you can notice the difference clinically in terms of their perfusion. They kind of perk up. They've got a palpable pulse. You can trace the A line. And then, depending on what the actual source of hemorrhage is, so if they've got a bad pelvic fracture, maybe you want to bind them, getting them up to the OR, pre-peritoneally pack them, plus or minus an X-fix and angio, versus maybe get to the CT scan to find the actual anatomy of the injuries, and then from there decide if you can bring the balloon down, go up straight to the ICU versus IR or the OR. And so much of this really depends on having established, accepted, collaborative, multidisciplinary protocols in place at your institution.
Yeah, that's exactly right. I think that's the key, though, that you mentioned is it's institutional dependent where you go after that balloon goes up, right? So some places it might be just faster to go to the OR and pack the pelvis after the balloon. Some places it's faster to go to the hybrid room and just shoot an angio and embolize. Some places you might not have access to either, and you need to buy time to get more information about the head or whatever. You go and get a CT scan to rule that out. So I think what happens is it is so institutionally dependent, where that patient goes afterwards, which makes it even more difficult to gather data, right? Because,
for sure.
Are you going to the OR because you can? Because you can't get to the angio suite because IR is not there yet, so all these things are driven more so by need, I think, than anything else. But it just, the fact that it's all it's intended to do is just buy time. That's it.
Right. Yeah. Temporizing measure until you can get definitive hemorrhage control. Last month in Journal of Trauma, there was a publication talking about the experience at different centers and looking at the success and timeliness of REBOA placement with balloon inflation based on whether or not you're a high volume center, meaning you're doing a boatload of these, versus intermediate versus low. And this was a survey that was sent out. It had a response rate of about 30% of participants. And it seems like the vast majority of trauma centers, at least in the US, have some experience with REBOA. But very few surgeons actually are doing more than 1 to 5 of these in a year's period. So what are your thoughts in terms of how we can maintain proficiency? And in centers where they're not getting a lot of experience, should they be performing this procedure or kind of sticking with the basics or fundamentals?
So I think we've demonstrated that the hardest part of it is the access. So that's something we can all practice all the time, right?
Right.
Especially if you don't have any residents or fellows, then putting that A-line in, making sure it's in the common femoral artery, using ultrasound, that kind of stuff that's something that we can all do, anytime. The procedure itself, it's pretty straightforward. If the access is good, then you know how easy putting that catheter is in the 7 French sheath. So it's really everything that goes around the procedure that is kind of where you get into the details about high volume centers, because there's some things that, if you don't do this procedure so often, you forget little things that you remember the next time you do. And your memory it's just like every procedure. There's nothing different about this. So, I think the A-line thing is easy. It's an easy fix to stay proficient in. I think reading about it, listening to others' experiences, sharing experiences is really important too. I know that I remember at Shock Trauma, we used to discuss every single REBOA placement at M&M, regardless of whether it went well or not. I mean, it could have been a great one, and we still would discuss it just to get everybody on board. But it's those other intangibles, like, the staff around you knows what's happening. The ICU knows what to look for. There's just so many, the ultrasound tech knows what they're doing when you ask for the duplex the next day or two. Right. It's just all of those things that I think really come down to, improving outcomes. And again, it's been demonstrated in other endovascular, procedures like carotid stenting, right? Higher volume centers, higher outcome, or higher number of, procedures per surgeon, the better outcomes. So this is no different. Absolutely not. The only difference is that we just don't have that many patients in most hospitals that need it. So I think skills sustainment is something we have struggled with for really since the beginning. We made a little module for asset, like an add-on asset. So, when you're in the cadaver lab doing asset, you can, practice REBOA. I think each institution that has a cadaver lab, they can tack that on to anything that they're doing in the cadaver lab, or animal lab if they have animals. And again, there's also just the dry simulators that those are extremely beneficial. And it doesn't even, the industry reps from anywhere happy to come out and, bring their simulator and just let everyone go through and practice. So I think at least every couple months, everyone should just be going through the motions, even though if it's, it's not necessarily in a cadaver, but at least just jog your memory, go through the motion, go through a case scenario. It's those kind of things that'll help us kind of in the long run, improve outcomes and decrease complications.
Yeah, I think the point you made about the intangibles, it's sort of some of the teamwork and some of that sort of crisis resource management. So if you're the lone trauma attending and now you're focusing on this procedure, you've got your ultrasound out. I mean, you're completely fixated on that groin and getting CFA access. And it's easy to kind of lose track of, all right, well, where are we in terms of the resuscitation? Is the whole blood here? Has the TEG been sent? What other adjuncts are going on? So yeah, I've always found that when we have two attendings or, there's at least another senior ER personnel there, it really does seem to go so much smoother. And again, a lot of that is going to be based on your institutional resources. So if you're at a level 3 out in the community versus at a level 1, it's going to be a real different sort of scenario in terms of placing these REBOA successfully. So in terms of the indications, it really seems like the indications for REBOA are changing. And like you mentioned earlier, we're still trying to define the right sort of patient subset that may potentially benefit from this hemorrhage control life-saving procedure. I think when it comes to these unstable pelvic ring fractures, it seems like there's pretty good buy-in that if you've got a non-responder, or if someone doesn't initially respond to some blood resuscitation, whether it's whole blood, plasma, or an MTP, that sticking in a REBOA may be a great adjunct to temporarily provide some hemorrhage control. Is that part of your algorithm when it comes to patients with unstable pelvic fractures?
Yeah, for sure. I think that's even worked its way into some of the association algorithms. Western trauma, it's, REBOA is always plus minus, but it's, it's in there. Yeah. The World Society of Emergency Surgery, it's in their algorithm too. So I think it's something that people are considering definitely for pelvic fracture hemorrhage. And again, it comes down to, resources, right? If you put up the balloon and pelvic hemorrhage, do you go to the OR and pack because you're waiting for IR, or is IR available and you can go right away? Is ortho able to, fix the pelvis for you before you're packing, or are you going to throw the sheet? All these things are very institution dependent, as you know. So I think the pelvic fracture hemorrhage, it's starting to become more of a possibility, and people are considering it more. The problem, especially in the data that the first few years we were doing it, we did so many more zone 1 REBOAs. So the data is kind of lagging along on zone 3 just a little bit, but there's some places that put in the REBOA at zone 1 for pelvic fracture hemorrhage, and then they'll lower it down to the pelvis once they're in the OR or in the IR suite. So the data for zone 3 is definitely lagging just a little bit behind zone 1, but we'll catch up. We'll get there.
Yeah. Oh, I believe it. It really seems like that for us is a no-brainer. If you've got that unstable pelvic fracture and they're not responding, just get that REBOA in, and provided that there's no free fluid on their abdominal fast and we're not concerned about intra-abdominal hemorrhage, just go straight to that zone 3 deployment, stop that inflow, and get some temporary hemorrhage control.
Yeah, exactly. That'll also save you from, the ischemia, any of the visceral ischemia. I think the only key is that if you go in at zone 3 in a bad pelvis and, you're sure your fast is negative and the abdomen's, as soft as you feel like it is.
Right.
If the blood pressure doesn't respond, just pop it up to zone, deflate it, pop it up to zone 1. And sometimes, we all know the fast exam can become positive the second time. Those things.
Oh man, how many times
you can always get
happened?
tricked, right? This is a humbling profession. So I think if the balloon goes up at zone 3 and you don't, you're not getting the response you're looking for, then try it at zone 1, and obviously, go for your resuscitation, all that stuff. Wrap a sheet around, put a binder, whatever you have. Just it's not always the algorithm always forks at many different roads. So if that doesn't work, try zone 1.
Yeah. And so for the placement of the balloon, you're using purely external landmarks. Is there really any need to inject contrast into the actual balloon, or are you just using saline?
So most of the time contrast isn't available, at least where I've practiced, to get quick enough. And so most of the time, honestly, I've just used saline. It's nice to have a little bit of contrast in the balloon, especially for pictures. It's easier to see under fluoro once you get to the angio suite. So it's really nice to have it if you do, but I would never let it delay, balloon inflation. If you're ready to do it, saline is just great.
So one of the early lessons that has been promulgated when it comes to the application of REBOA is not to use it in patients with potential thoracic trauma. And therefore, we're going to get a portable chest x-ray very early in the management of patients in order to determine who may or may not be a candidate for a REBOA placement. This month, JT, I see that you were the senior author on a paper coming out of Calais, Colombia. And it looks like the group there is now looking to expand the use of REBOA to patients with potential intrathoracic vascular trauma. So I guess my question here really, Dr. Brenner, is, are we pushing the envelope too much? Are we looking for indications to apply REBOA? What are your thoughts in terms of the ever expanding role of this technology and approach?
Yeah, sure. They, Carlos Ordonez and his group down in Cali, if you look at their demographics, they're like almost the opposite of us, right? They take all their trauma patients and the majority are from penetrating trauma. That's the way it is. So they have done a phenomenal job of, they have obviously the same problem, right? Non-compressible torso hemorrhage. It's everywhere, whether it's penetrating or whether it's blunt. Obviously, we have the data here for blunt, but not so much penetrating. So they're really spearheading, REBOA for penetrating trauma. But what they have is why it works, at least for now, is they have 2 teams that are dedicated to the patient. So one team is the surgical team, and they don't put REBOAs in the ED, right? The REBOA only goes in the OR with 2 surgical teams there. The one team is getting, doing the XLAP or the thoracotomy, getting proximal control, right? So controlling that hemorrhage that's above the level of the diaphragm where the balloon's going to go. The other team is responsible for inserting the REBOA. They do resuscitation. They're doing everything related to REBOA is the responsibility of that second team. So, it couldn't be in that's an ideal situation, right? If we all had 2 surgical teams, we would I mean, the possibilities are obviously endless, but that is why it works in their algorithm, is because they do have the resources to do that. Obviously, the reason why we, recommend that it's probably not a good idea here in the US is because it's being performed in the ED right now, right? So if you have a question or a concern of, thoracic hemorrhage, then doing it blindly in the ED when you don't know where that injury is, right? Most thoracic hemorrhage is going to be, if the patient makes it to the hospital, it's not, their thoracic aorta is not going to be, there's not going to be a transmural injury because they wouldn't make it. So the chances of it being an injury that won't get necessarily that much worse, it's certainly possible. But the fact that we don't have access to it in the ED, it's a little bit concerning, especially since we're just beginning to, develop this procedure. We don't want to, just say, throw it in there. No big deal. Let's just see what happens. So we're trying to be careful and safe and kind of move this forward, in the safest way possible. But those guys down there are doing a phenomenal job of, pushing that envelope for thoracic injury. For penetrating abdominal trauma, I think it works, it's the same way as blunt, right? If the patient's bleeding, you need that at zone 1. So it's really the thoracic hemorrhage that they're definitely leading the cause for. But again, when interpreting that data, you got to remember their setup, right?
Right.
That's why it works.
Yeah. I saw there was about half of the patients, or just under half of the patients in that particular series, had some major thoracic vascular injuries. And so when we talk about a zone 1 deployment for someone with a potential thoracic vascular or major vascular injury, is just above the diaphragm good enough, or are they kind of like targeting even more proximal?
So just above the diaphragm is fine. And it is fine only because they have control of that hemorrhage above the balloon. Right. So that's the only reason that's why that works, is because that second team or first team, whichever they're defined as, that surgical team has their finger on the hole in the subclavian. Right. So that's why putting it anywhere in the thoracic aorta is still going to be okay, because you have that proximal control. So again, that's the only reason it works. If you can imagine a hole in the subclavian in the ED, right, and putting a balloon at zone 1, you'd probably get a lot more hemorrhage. Maybe the patient would die, maybe they wouldn't. But at some point, there may be some fine line between the resuscitation. It's a trade-off, right? It's a risk benefit. You need the resuscitation more than the blood loss that will ensue from putting it there. So, but we're not quite there yet to put it blindly, I think, in those patients. But they've done a great job developing an algorithm for that situation to use it in, because honestly, out of necessity, right? They get those patients so much more often, and the results are great. So far they're demonstrating it's certainly feasible and helping their patients.
So over the last 7 years, Dr. Brenner, it really seems like this topic of REBOA has really been polarizing. It seems that on the one hand, you have folks like myself who think that in the right select patient population, REBOA may actually be clinically useful as an adjunct to hemorrhage control. And I always talk about patients with severe hemodynamically unstable pelvic fractures as a great example, who, again, are transient or non-responders to initial conservative management. Then there are those who really seem to be very against REBOA. And I'm just trying to understand and want to get your thoughts. Why do you think this is?
Yeah, I think that's normal with everything that's new, right? There's people that are just going to hate anything new just to hate anything new, regardless of what it is. Those, people have made up their mind sometimes without, hearing or listening, and they don't want, we're not here to force anyone to do anything, right? We're just trying to figure out a better way to do things for our patients. If people want to learn, we're here for them. If they want to hear some data, we're here for them. It is, I think every new anything is polarizing. But those people that say, oh, it knocks off kidneys, that, people lose limbs, they're not wrong. We've seen that happen. They're 100% correct. This is not, something that is without risk. The incidence of systemic complications, the incidence of access complications, the access complications have significantly decreased with the, lower profile device. The systemic complications, those obviously have not changed because it's, balloon occlusion of the aorta. That's not, whether it's through a 7 or a 2 or a 20 French, it doesn't matter. So those people are not wrong. But again, that's part of what we need to figure out and how to make this, safer. At some point, we're not going to be able to eliminate those, right? So we got to remember that the incidence of AKI, it's actually in some series, it's less than patients that don't have REBOA that are just hemorrhaging, right? So,
Right.
you got to take the complications in the sense of, well, these patients come in, in near arrest or in hemorrhagic shock. So they're obviously, they're already starting, behind the eight ball.
Right.
So their kidneys are going to take a hit. Is the REBOA going to make it worse? Yes, possibly. But they also might die. So we've got to try and balance that in terms of complications and hemorrhage control. So that's just a balancing act. And a lot of the critics and the people that, don't agree with it, a lot of that is really helpful. That helps us have conversations that drive, where we go with the studies, what data points we're
Absolutely.
looking for. So all of that is good if it's done, in a professional manner.
Now, in terms of trying to decrease some of these end organ ischemic complications, P-REBOA or partial REBOA is something that's being actively researched and discussed. What are your thoughts in terms of P-REBOA in terms of decreasing some of that ischemic burden and its effect, or how good it is at decreasing hemorrhage, yet allowing some oxygen delivery to distal organs?
So I think theoretically it makes perfect sense. I worry sometimes that people will be obsessed with the balloon, you know, putting, injecting, inflating, deflating. Oh, how many minutes? So that takes away from just going and getting hemorrhage control. Just
Right.
so I think back to, vascular training, and, obviously this is the same like ruptured AAAs. We'd put in the balloon, it would go up, and it would be fast and furious to get hemorrhage control, and then the balloon would come down, right? So, I wonder, well, should we have been doing the partial back then in these cases? And I think, well, maybe that would distract me too much from just going and stopping the
Right.
blood, just stopping the hemorrhage. So
Yeah.
I think that's an issue. Maybe theoretically, I haven't really had any experience with partial. I usually just fully inflate. The blood pressure is where it needs to be, and I just don't, I just go from there. Joe DeBose has a ton of experience with partial. He does it every
Hmm.
time. There's a lot of people out there that use it, that prefer it. And, again, I think at this point, we're still trying to get people to understand REBOA,
Right.
period. So
Hmm.
partial has even less data. We are going to have data, as soon as the new catheter gets into the hands of the people that do partial. The new PriTime device was just FDA approved and has little flow channels in the balloon. So basically to allow some blood flow beyond the balloon. So I think that's going to be really exciting to see, whether that makes a huge difference or not. So we are looking to the partial REBOA users to, get that in their hands and let us know how it works, and maybe we can reduce some of those complications.
So far, we've really focused and centered our discussion around balloon occlusion of the aorta. And obviously, there's going to be many more patients who would require arterial occlusion than venous occlusion. But several years back, I remember a few case series and reports, kind of animal models, looking at the potential utility or application of REBOC, or resuscitative endovascular balloon occlusion of the vena cava. Obviously, these retrohepatic cava injuries are few and far between, but have there been any new advances when it comes to vascular and endovascular approaches to patients with these rare but devastating injuries?
So there's not as much, obviously these patients are few and far between,
Hmm.
but they don't do well. None of them, right? So if you're lucky enough to get one through, but unfortunately they're the ones that are still, they're still the ones that are dying on the table, despite
Yeah.
everything. So there, as you mentioned, there's some case reports of using even the REBOA balloon in the IVC. Again, it's a little bit different because you don't know that there's a retrohepatic caval injury until you're in there. So this
Right.
isn't obviously something you're doing in ED. You're literally in there and using it in the OR. The REBOA balloon is long. It's not completely long enough to cover the entire retrohepatic cava. But there is a balloon out there called the bridge balloon that we have used in cadavers. And there's been some, I believe, some case reports. I'm not sure if they're published at this point, but that balloon has been used, to try and diminish the, mortality from those injuries. And again, in theory, it makes a lot of sense. But you have to remember that occluding the cava is going to cause some physiologic
Some minor physiologic
devastation, I
changes.
would say. So I think I've never, had that experience clinically, but in my mind, I would probably also do a REBOA as well as
Yeah.
have, a huge central line, subclavian cordis, just, slamming blood in at the same time. That would be the way I would envision it. But those injuries are really hard because you can't always repair them, even if you have control of them. Some of those,
Right.
depending on what the injury is, if it's in the cava, okay, you can sew that up, and it's much easier said than done. But if it rips all the hepatic veins, and then it's just so we do the best, just like everything, we do the best we can with what we have. But that balloon has not been, advertised for anything other than it's actually used. It's used for the SVC and EP lead removal in case of massive hemorrhage there. So that's kind of how we stumbled upon it. But we do have a kit at Shock Trauma. We had one made that has that balloon in it and goes through a 12 French sheath in the femoral vein. But just, the number of times that is needed and
Right.
so far has been used, we just don't have any data on that yet. But
yeah,
again,
not surprising.
It's not without physiologic compromise.
Sequela.
Yeah.
Yeah. Earlier, you were talking about the Cali experience, and about 2 weeks ago, we had initially a non-surgical patient who came in with a massive GI bleed that they were able to temporize endoscopically, and we got reconsulted kind of very, very late in the game, like peri-arrest, for this patient who was really behind the 8 ball. And, she had gone into cardiac arrest. We were able to get her back. About 4 attendings all came down to the operating room, and 2 of us put in a REBOA while the other 2 were doing an X-lap and getting ready to get hemorrhage control and oversewing of the GDA. Unfortunately, she was so physiologically devastated by that time. It didn't work. But in theory, this seemed like a reasonable approach. And so where are we now with the use or expanding indications for REBOA outside of trauma for patients? We've talked a little bit about ruptured AAAs, but what about GI bleeds? And then use in obstetrical patients who are at a high risk for hemorrhage. What's your experience there? And is that coming along as well?
So I think that because it's acute care surgeons and trauma surgeons that have this skill set now, obviously, we're being called to do it elsewhere. I think that just as in trauma, obstetrics, it's one of the highest causes of maternal mortality. So that is going to be, and it's already being used in, many centers that already do REBOA. There's a couple of series that are published out there. Again, the Cali group has published a series on postpartum hemorrhage. They've done almost as many for postpartum hemorrhage as they have for trauma. And there's some centers in the US that haven't quite published their series, but they've done quite a few for PPH. And we're going to try and get a trial going here for a multi-institutional trial to start to collect that data. Anecdotally, what we have found is there is an incredibly high rate of thrombosis, of access site thrombosis in these postpartum hemorrhage patients, much more so than trauma, even with the CODA and the 12 French. So I think there is obviously the coagulopathy of pregnancy we do not understand. It is not the same as trauma. So we need to be incredibly careful when we're using it in these patients. And I would advocate, some places started actually just putting in a 7 French sheath and putting the catheter in the aorta and just waiting and maybe inflating the balloon and maybe not during these C-sections. But I would not advocate upsizing to that 7 French unless you're going to use the REBOA. It's just the risk benefit is just not quite there yet. Again, as technology advances, there will be smaller, lower profile devices that, can go through something like an A-line or a 4 French sheath. So that will make that type of complication certainly reduce that, and it'll probably become hopefully used more for that purpose. But postpartum hemorrhage, I think, is going to be the second most common use for REBOA. In terms of cardiac arrest, like medical cardiac arrest, there was a recently published article. There's a group in Norway who's done a bunch, and so far, if we can get a non-inferiority outcome out of REBOA, and again, there's nowhere to go but up, right? These patients, we're not doing any better with that So I think it's, we're going to start seeing it used for that. And then the GI bleeds, right? The visceral aneurysm ruptures, all of that. There's plenty of case reports in the literature describing those cases. Theoretically, it makes perfect sense. But again, just like you mentioned, you got called too late, right? The key is to let your NICU colleagues, your medicine colleagues, your OB colleagues, let them know that you have a way to help them when they get into deep trouble, and then they'll call earlier. So, we develop algorithms with our OB partners. They'll call us when they know that they have a scheduled high-risk section. We actually do it. We'll post it in the OR rather than in L&D. That way everyone's on board, anesthesia's ready, we're ready. So it's really it's not just having the technology or knowing how to do the procedure. It's, letting your colleagues know and be aware so that when they get into trouble, they know who to call, or if they think they might get into trouble, even better.
Yeah.
Give us a heads
be
up.
prophylactic about it. Yeah. Especially with the, you got a patient, high risk OB, placenta accretia, they're going to bleed. Again, having some form of femoral artery access. And then if you don't need it, fantastic. If you need it, you're good to go. So I think, like you've mentioned, the multidisciplinary nature of this procedure is critical. Education, maintaining proficiency, as well as raising awareness amongst our non-trauma ACS colleagues to let them know, hey, we've got this device available and it may potentially help temporize or staunch bleeding while we get definitive hemorrhage control. Yeah.
And when it comes to, also in trauma, of course, but when it comes to doing it, with other specialties patients, obviously getting your vascular surgery colleagues on board is just as critical, because they can certainly give a hand, help out, and especially when it comes to complications, which again, we're seeing much more of in the postpartum hemorrhage patients, they can be obviously extremely, extremely helpful for that. So it's really the multidisciplinary thing is, it's not just who's patients, but it's who can help us take care of the complications.
Yeah, and getting back to patients post-cardiac arrest, is this crazy? The idea of putting in a REBOA to help with coronary circulation as well as cerebral perfusion in the setting of cardiac arrest. From a physiologic standpoint, sure, you increase the afterload, you're going to improve the patient's cardiac output and retrograde flow to the coronaries and brain. But this seems like we're kind of pushing it a little bit too much. I'd love to hear your thoughts in terms of pushing the envelope of this technology to the care of medical patients.
Yeah, I think it's going to be, when it comes to medical cardiac arrest, it's going to be a very different animal, especially if the cardiac arrest is obviously based on a cardiac dysfunction. I think that as soon as ROSC occurs, which hopefully won't take more than a few minutes, I think that balloon's going to need to come at least partially down right away. Whereas in trauma, we can leave it up for quite a while. Our patients' hearts are usually pretty healthy, so they can handle the afterload. But I think it's going to be a very different game for medical cardiac arrest, especially when it's truly cardiac related.
On the topic of deflating the balloon, I've just started to give bicarb when we put the balloon down. Is this something that we're seeing? You got to imagine, depending on the duration of balloon inflation, there are going to be metabolic sequelae. And I've seen reports of hypocalcemia. I'd imagine that's probably more related to the fact that patients are getting massive volumes of RBCs with the citrate. But is that something that you recommend doing, or go on the basis of blood gas analyses, or don't give it at all?
So I think, there's no data to support any of that. If we look at the vascular surgery literature with, how they've handled ruptured AAAs, that's probably the closest in terms of data that we have. The difference being that, it's obviously a little bit different. Our patients are a little bit different than the ruptured AAA. Most of them are a little bit younger and healthier. But bicarb, certainly calcium, it's always critical, just like, even if you're not doing REBOA, right, to get your set of labs before you start kind of winding down, seeing where you're at. And it's obviously very individual. Some patients have no issue with the ischemia. Reperfusion is very minimal in some of them, and in others it's not. It's profound, and they can arrest, to be honest. So I don't think bicarb is a bad thing. I just think we just don't know how and where and when exactly to use it for specifically REBOA. But if that's something that, if the lab's demonstrated and you're worried about I don't think there's anything wrong with it. But again, I have no data to support any of that.
So, Dr. Brenner, you've been at the forefront of REBOA, and over the last several years, we've seen some significant changes in the indications as well as the technology regarding resuscitative endovascular balloon occlusion. Where do you see things going in the future? What are some of the next big steps or milestones that you envision for this technology and practice in acute care surgery patients?
So I think we're going to continue writing, collecting the data, writing about it as our experience increases. But just like we saw that huge exponential adoption with the new technology, I think we may see that again when even newer technology comes out. It's going to be kind of a combination of the data and the technology. And we're still going to have people that are never going to adopt it. There will be people who will be more interested maybe with a smaller device. So it all kind of will come hand in hand, just like it did for the first, back in 2016 when there was the beginning of the surge. So I think really technology and data are going to drive it. The training, I think there's plenty of training opportunities out there. There's several different courses. There's industry, demonstrations, as introductions. So I think that, all those things are going to combine, but usually it's technology that really, really drives, the adoption, and the data will help us fine tune, who to use it in, when to use it, what adjuncts to use it with. So, that'll happen kind of organically as we get all that together.
Yeah, of course. A few episodes back, we had Dr. Sam Tischerman on the show. I know he's a buddy and colleague of yours, or former colleague at the Shock Trauma Center. And it was fantastic to hear some of the amazing work that he's been doing over the last few decades on EPR. And we talked a little bit about the actual multimodal approach to EPR, as well as the potential use of REBOA, in addition to other procedures like selective aortic arch perfusion in patients with cardiac arrest following penetrating, exsanguinating torso trauma.
Yep, for sure. I think it's and REBOA is just one, it's one procedure. There's a lot of great work being done, with selective aortic arch perfusion, right? And injecting into, it's just one component of kind of where resuscitation and trauma are heading. It's going to be really exciting to, kind of see where it is in the next little while.
Fantastic. So before we check out Dr. Brenner, are there any final take-home points or messages that you would like to convey to our listeners?
I mean, I think when it comes to REBOA, just learning how to do it well, learning how to do it safely, and remembering that we're doing a procedure that has not been proven with level 1 evidence, but there's a lot of procedures that we do on a daily basis that haven't either. So we just, do our best to minimize harm and hopefully improve, outcomes. And as soon as we have anything to share, we certainly will do our best to do that. But for now, just, use your best judgment, your best training, and do the best you can.
And that wraps it up for another episode of Trauma ICU Rounds. I'm your host, Dr. Dennis Kim. If you like what you're listening to, please make sure that you let us know. Leave a positive comment at Stitcher, Spotify, or Apple iTunes, wherever you download your podcasts from. If there's a specific topic or issue you want discussed, or a past or future guest that you think would make a great addition to the show, please let us know. You can DM me on Twitter at Trauma ICU Rounds. You can visit the website, traumaicurounds.com, or send me a message via Gmail, traumaicurounds@gmail.com. Until next time, please do stay safe, continue to read, take care of yourselves and one another.